everyone. Welcome to the session, Treatments for Pulmonary Fibrosis. Before we get on with our fabulous speakers, just some housekeeping notes here. If you have any technical issues, there is a green message support button on the lower right corner of your screen. For any PFF questions for today, please click the Help Desk button on the menu ribbon at the top of your screen, and you'll be connected to any one of our PFF staff. And our speakers will be answering questions related to today's talk at the end of the session. So you can submit questions anytime during the session. Please use that little Q&A tab on the interaction panel to the right of the video, and we'll try and get to as many questions as possible as soon as the talks are complete. So I'd like to welcome our speakers for today. We have Dr. Rupal Shah, who is an associate professor at the University of California, San Francisco. She co-directs the ILD program there and clinically works in both ILD and lung transplant. And she is the medical director of the adult patient experience for UCSF Health and is passionate about providing outstanding patient-centered care. Jamie Letter is our second speaker today. She's a nurse practitioner with the University of Pennsylvania Interstitial Lung Disease team. She's worked with that team since 2016, and she has been a nurse practitioner since the fall of 2013. And when she is not working and caring for our patient population, she is a big Philly sports teams fan. Dr. Shah will be discussing medications for pulmonary fibrosis, as well as provide an overview of lung transplantation. And Jamie will go on to present treatments such as oxygen and pulmonary rehabilitation.
Thank you so much, Dr. Lee, for that kind introduction. I'm really excited to be here to talk about two of my favorite topics, lung transplant and medications. I will say, when they reached out to me about this and then told me I had 20 minutes, I felt a little overwhelmed. There's a lot to talk about. So I thought the way I would approach this is thinking about the things that my patients ask me in clinic about lung transplant and medications, and try to go through what are the common things that people worry about or wonder about. And I purposely made my talk a little bit on the shorter side so that I could answer questions at the end, because I want this to be as beneficial to you as possible. So, common myths about lung transplant. I put this cute comic in the on the side, but that really is the first myth, right? Transplant is not an in and out, it's a lifelong process. And just to go over the basic surgery for those of you who don't know anything about transplant, we do get donations from organ donors. We do not do living donor lung transplants in adults. And in general, the operation is 8 to 12 hours, an incision across or down your chest, have your lungs taken out and donor lungs put in under surgery, and then there's a recovery process. So one day, maybe we'll get to an in and out, but for now, it's a lot of time in the operating room in the hospital. Some of the other questions I hear in clinic are, I'm worried that I won't get that much benefit from transplant. I don't think I qualify for transplant for various reasons. When I get my transplant, I'll feel better immediately and I don't have to see a doctor again. I'm worried that my lung disease will come back. How do you know that transplant is really going to be a cure? 2 lungs are better than 1, so I only want a double lung transplant. So I'm going to go through some of the data and information around all of these themes to help us sort of be on the same page about transplant. So first, will I get benefit from transplant? There used to be that patients would always be told, well, I don't know if lung transplant is worth it. There's a lot of complications and you're going to die in 5 years. And what we know from the information from our largest international registry is that survival continues to improve in every era that we look at. We are seeing patients live longer and longer. And you can see in these graphs, the green line is the most current data, and that line is a little bit higher than the lines before it. And I expect that when we look again with more updated data, the survival will continue to improve. So we know that over 80% of patients survive the first year and over 70% of patients survive the first 5 years, with the median survival probably over 6 years, and at some centers even up to 10 years. So we know that, especially for fibrosing lung disease, in many patients, transplant does offer a benefit as far as how long you'll live. But what about quality of life, right? I could live for 10 years, but if my overall quality of life isn't great, maybe transplant isn't worth it. So this has been another topic of study. And what they've shown is that people who have undergo transplant tend to do better as far as the amount of physical activity they can do. They also have improved mental health, lower rates of depression, improved emotional function, and overall seem to enjoy life. And that benefit, as you can see in this lower graph, is sustained over time. So it's not that we just see a benefit after transplant and then it kind of trails off. We see that patients, at least up until 3 years, tend to continue to experience improved quality of life. So moving on to, will I qualify for transplant? Am I a reasonable candidate? And there's a busy table over here that I don't expect you to read, but there are guidelines for patients as far as who qualifies and who doesn't. In general, we think of patients who qualify for transplant as having single organ failure. What that means is that your only real problem is that your lungs don't work. If you have other organs that don't work well, for example, kidney disease or liver failure, or your heart doesn't work well, then we worry that you wouldn't be able to tolerate such a big surgery and we wouldn't move forward with transplant. If you have an infection that we think will get worse after transplant because the anti-rejection meds suppress your immune system, that's another issue. If you feel like mentally you're declining and medications may be challenging, or your life expectancy may be limited by another process, then we would decline for transplant. Active substance use, active smoking, drug abuse, those are reasons that we wouldn't move forward with transplant. And then if you have an uncontrolled autoimmune disease, meaning your joints are flaring up, your muscles are weak, we would want that to be controlled before transplant. Similarly, if you have cancer, we would also want that to be treated and often need to wait some time before transplant. So there are some contraindications to transplant, but in general, many of patients with fibrosis will qualify for transplant. I didn't put age up here, which is another major exclusion criteria. The age is not guided by our international society, and the age cutoffs vary between centers. So what we can see is that over time, we've transplanted older recipients. So it used to be when I first started that we really wouldn't transplant over 65. That was our cutoff. And now there are some centers that are transplanting up to 70 and others even up to 75. What we're seeing is that the survival, you can see here on the bottom left, tends to increase over time, even in our oldest recipients greater than or equal to 60 years. Similarly, we have found that the body mass index, or a combination of your height and weight, also is a risk factor for doing poorly after transplant. And so we know that a body mass index greater than or equal to 35 increases your risk of challenges after transplant. But we have found that if we transplant around 30 or a little bit above, that we manage to do okay. So what we're saying is that more and more people are now eligible for transplant, including older recipients and patients with elevated body mass indexes. What does life after transplant look like? What would you have to go through to get a transplant? Typically, you're in the hospital after surgery for 2 to 3 weeks. Most centers want you to stay close to their center for 6 to 8 weeks. Those early time after transplant is really challenging. We have to monitor your medications very closely, make sure you don't have any complications. My patients often ask me, well, when will I feel back to my old self? When will I be able to do all the things I want? In general, when patients leave the hospital, they're off oxygen. Most patients are able to walk, maybe with a walker or with assistance. And by 6 to 8 weeks, most patients are walking independently. And by 6 to 12 months, we feel like you're kind of back to your old life. You're able to do the things that you enjoy. You are on lifelong anti-rejection medications. Those medications work by suppressing your immune system. And this is why I tell patients there's no free lunch in transplant. You're kind of trading in your old lung disease, which could potentially kill you, for a transplant, which is curative, but the medications have a lot of side effects. And you can see this table lists some of them, but often our patients develop high blood pressure, diabetes. They can have kidney issues, high cholesterol, all things that I can manage, but certainly you're always connected to a medical center into our clinic for life because there's a lot of monitoring and potential complications. So it is frequent visits to the clinic, frequent bronchoscopies, and frequent blood draws after a transplant. However, you also should be able to regain your quality of life. So this is one of our patients, and here he is scaling up Yosemite, which is pretty impressive. And even though that is sort of the exception as someone who's still rock climbing, the majority of my patients are hiking, walking, spending time with their family, enjoying a great quality of life. And so for the right patient, transplant can be transformative. Will my lung disease come back? It's very unusual for interstitial lung disease to come back. There are a couple of lung diseases that can come back after transplant. The ones we commonly see are sarcoidosis, lymphangioliomyomatosis, and Langerhans cell histiocytosis. Those are rare diseases, but they can come back. When they do come back, they are rarely clinically significant, meaning you may find them on a CT scan or through a transbronchial biopsy, but they don't usually cause symptoms. The times that I have seen lung disease come back in a significant way is if someone had a disease called hypersensitivity pneumonitis or a disease related to an exposure, and then were re-exposed to that disease, that exposure after transplant. So for example, if my lung disease was because of a bird, then I got rid of my bird, but unfortunately I progressed, got the transplant, and then I went back, got a bird again, there is a chance that that would come back. Otherwise, we do not see idiopathic pulmonary fibrosis come back, and it's very unusual to have clinically significant return of your lung disease. And then the question I get asked most often is, well, should I get one lung or two lungs? And I will say that there's a lot of factors that go into that decision that are unique to each patient. But when we ask, well, is one lung better than two? Again, the green line here in these graphs is the most current survival area. And you can see that the graph on the left side of my screen is single lungs and the right side is double lungs. And you can see that the survival for a double lung transplant is better, but the early survival is similar. And so what we know is that a lung transplant tends to have less complication, better early survival, but if you're able to survive kind of that first year, then a double lung transplant offers more benefit. And so when I think about single versus double, I really talk to patients about their unique situation, what the risks are for a transplant, would one be better than the other? And this has also been studied sort of looking at what's the benefit to society, meaning if we did all single lungs, maybe we could transplant double the patients, versus if we did a double lung, some patients might live longer. And you can see here that in the bottom right, patients with COPD tend to have similar survivals with singles or doubles. So in the carefully selected patient, a single lung transplant is perfectly acceptable and often may offer an earlier transplant than waiting for a double. So that's something to kind of think about as you go through the transplant process. And certainly your lung transplant doctors will talk to you about this in depth. So to conclude the transplant part of this talk, my goal is that patients are referred early. There's a lot to understand about transplant, and there's a lot of evaluation that needs to happen to see if you're a candidate. And so the earlier you come to our attention, the better. You are your own best advocate. We don't want people to be referred late. So if you're interested in transplant, don't hesitate to ask your pulmonologist, even if they haven't brought it up. Sometimes it's not on their radar, but you asking the question can trigger the referral. Certainly, transplant isn't for everyone, but it can make a big impact on quality of life and overall survival, and outcomes continue to improve each year. Okay, I'm going to turn to medications. Again, things that I get asked in clinic, do the medications really help? Is it worth it for me to take it? I'm going to have so many side effects. It's not worth it. My quality of life is going to be terrible, and they're so expensive. So of course, I don't want to be in a situation where I prescribe you something and then I prescribe you 5 other things to deal with the medication that I prescribed you. So let's talk a little bit about these issues. So when I think about pulmonary fibrosis, there are 2 big categories of medications. You may not see the medication that you're taking on this list. There are a lot of different lung diseases and different medications that people prescribe, but I think of these two as big categories: antifibrotics, pirfenidone or the brand name Esbriet, nintedanib or the brand name Ofev, and then another category of drugs that suppress your immune system, which is prednisone or steroids. And then there are several drugs here that are used instead of steroids commonly. I'm going to start by talking about pirfenidone and nintedanib. And the question is, do they work? You can see here in these two graphs that the lighter line or the bottom line is those patients who are taking placebo. They're not on any therapy. And this is a graph of their lung function over time. You can see in the lighter line that they're declining faster than the dark blue line. Both in pirfenidone and nintedanib, you see a similar change, that both of those drugs slow the rate of decline. Now you can also see there's a dashed line at 0. What they don't do is keep you exactly the same or make you better, but they both slow down your fibrosis such that you have more lung function for longer. In addition, these drugs have been studied in diseases that are not idiopathic pulmonary fibrosis, but that are progressive fibrosing lung disease. So you may have a disease that's not called IPF, but is causing more and more scarring over time. And what we see is that in that population, in this study, it was nintedanib also slows the rate of decline of lung function compared to doing nothing. But what about side effects? Is it worth it? You're telling me I'm not going to be cured, and you're just telling me I'm slowing this down. Is it worth it for me in terms of quality of life? So this kind of goes over this table, sort of the benefits and side effects of both nintedanib here and pirfenidone. Both of them reduce the rate of decline in your pulmonary function. They probably reduce the risk of acute exacerbations. There's also increasing data that it probably reduces mortality. And we're getting more and more information about that. Both of them should be taken with food. Nintedanib is twice a day, pirfenidone is 3 times a day. And both do have side effects: diarrhea, most commonly in nintedanib, stomach upset, as well as a rash in the sun with pirfenidone. And both need liver function monitoring. Nintedanib has a very small risk of heart issues. They're both expensive. You can see close to $100,000. They also both have impact on quality of life, so shortness of breath, as well as sort of symptoms related to fibrosis. And so with this data, what we have is that they do reduce the rate of decline. There are side effects. I will say that in general, I am able to manage the side effects with lifestyle changes or other symptomatic medications. And you can see here that about 80% of patients are able to tolerate these drugs. And I did point out that the cost is high, and I just want to refer people to this excellent website on the PFF Foundation, which really goes through what resources we have if the cost is prohibitive. That we don't want anyone to not be able to get access to these medications because of cost. And there is certainly opportunities, and I did not list them all here, for ways to reduce the cost for you. So please don't hesitate to check that out if you're concerned about cost. Finally, I wanted to spend a little bit on immunosuppression, because some of you may be on drugs to suppress the immune system. And what we can see is that drugs like mycophenolate mofetil or azathioprine, or drugs that basically reduce your immune system over time, can increase or stabilize lung function as well, both in autoimmune disease and in hypersensitivity pneumonitis. So these drugs we know are also effective in treating lung diseases that are not idiopathic pulmonary fibrosis. Immunosuppression medications do have side effects. They increase the risk of infection, cancer, and they can cause bone marrow issues, liver issues. Again, all of these risks can be addressed with appropriate monitoring, vaccines, and precautions. All of us are trained to look out for these. And in general, if we're recommending immunosuppression, it's because we believe that the benefits outweigh the risks for you. So in conclusion, both lung transplant and medication therapy can offer benefits in the right patient. And I really encourage you to have thoughtful conversations with your own treating team to decide if the benefits outweigh the risk for you. And then it's just my own personal plug that the more that we can support clinical trials, the more we can find drugs that will be better than what we have now, because ultimately we still continue to look for a cure for pulmonary fibrosis. With that, I will end and turn it over to the wonderful Jamie Lederer.
Thanks, Dr. Shaw. I'm Jamie Letter. I'm the nurse practitioner at the University of Pennsylvania, and I'm going to continue our conversation about treatments for pulmonary fibrosis, but we're going to talk about non-medication type treatments. So we're going to talk about pulmonary rehab, and we're going to talk about supplemental oxygen. Both are big topics that could take well over the amount of time that we have today. So I'm going to give you some resources at the end of where you can get some additional information about these topics. We're going to start with talking about pulmonary rehab. What is it? What's involved? And then after I convince you that you should be involved in pulmonary rehab, I'm going to tell you how you enroll. And then we're going to talk about supplemental oxygen, which we could talk about all day. It's the hot topic, right? So again, I'll give you some resources at the end, but we're going to talk about why do I need it? Then how do I get it? And then common questions and myths that come up in the clinic when we talk about supplemental oxygen. So we're going to start with pulmonary rehab. What is it? Pulmonary rehab is an exercise training program. They are going to teach you and have you exercise, but also during the program, it involves education on managing your disease. You also get to learn and develop behavioral health changes and strategies so you can develop healthy behaviors that are going to help as you live with a chronic lung disease. Generally, these programs are 12 to 16 weeks initially, and usually they meet 2 to 3 times per week. They involve cardio and strength training. They involve the education that I mentioned. And one of the really important things is they occur in a safe environment. Many of my patients say to me, well, Jamie, I have a treadmill at home. Right now, it's just collecting the clean laundry that I haven't put away yet, but can I exercise at home instead of going to pulmonary rehab? And while I also have exercise equipment that's collecting laundry instead of me exercising on it and would love to utilize it, when you have lung disease, you worry about, what am I doing? Am I harming myself? So when you go to pulmonary rehab, you have additional resources that are able to say, okay, you're short of breath, but your oxygen level's okay, everything's good with your heart, and we can keep going. Or we need to stop and make these adjustments. So you can learn what is safe to do so that when you finish the program, then you can put that treadmill that you have at home to use and know that you're doing it in a safe way. So I think it's really important that you get a chance to learn to exercise in a safe environment. So what are the benefits of going to pulmonary rehab? I'm asking you to leave your house 2 to 3 times a week, and what are you going to get out of it? So patients that participate in pulmonary rehab report decreased breathlessness. In a lot of these lung diseases, we can't make your lungs actually better, but what we can do is do things to make your body use the lungs that you have better. So if we build your muscles up, they put less demand on your lungs and your heart, and that results in decreased breathlessness. Patients also report improved strength. So many of my patients that come into the clinic have been short of breath for a long time, and they said, I've stopped kind of doing most things. And that old saying, use it or lose it, is very true when it comes to our muscles. So if we're not using them, then we get weaker and weaker and weaker. So going to pulmonary rehab, exercising on a regular program helps improve strength. Patients also report decreased anxiety and depression. I think a big part of this is because patients are getting out of the house 2 to 3 times a week, right? Having an appointment that says it's time to go somewhere gets you out of the house. You're also surrounded by other people that are in similar situations, so patients find a lot of support in going to pulmonary rehab. And we talked about decreased breathlessness and improved strength, right? If you feel less short of breath, that's going to help decrease your anxiety. A lot of my patients come back into clinic and say, my favorite part of pulmonary rehab is the socialization that I got, and it really has added to my life. And then patients that have gone to pulmonary rehab report improved quality of life. And I think that goes back to the 3 things that we just talked about, right? If you're less short of breath, you feel stronger, and you have less anxiety and depression, it's all going to improve your quality of life. So now that I've sold you that those things are going to really get you to sign up for pulmonary rehab, how do you enroll? So you're going to need a prescription from your provider. And then we generally recommend to our patients that they find a program close to home. We talked about that this is 2 to 3 times a week. And At the University of Pennsylvania, we have patients that travel an hour, 2 hours, sometimes even more, and they say, oh, should I come to the University of Pennsylvania for pulmonary rehab? Let's be honest. If you have to travel an hour to 2 hours 3 times a week, how many excuses are you going to make that you're not going to go? So we want to remove as many barriers as we can. So finding a program close to your home can be really important. And there are two websites, livebetter.org, which is from the American Thoracic Society, and then the American Association of Cardiovascular and Pulmonary Rehab has a website that have program directories on them. You can go to either of those websites, put in your zip code, and a list of programs and how far they are from your house will pop up. So check out those websites, and then you can ask your provider for a prescription so that you can call the program and enroll. So I do have patients say, can I exercise at home instead? For some patients, their work schedules are not compatible with kind of going to pulmonary rehab 2 to 3 times a week. During the height of the pandemic, many pulmonary rehab programs were closed. Some pulmonary rehab programs right now still have a waiting list because they're catching back up from when they were closed. So the Pulmonary Fibrosis Foundation actually developed a great resource, their Pulmonary Rehabilitation Toolkit, and you can find that on the Pulmonary Fibrosis Foundation's website. You'll find videos there that walk you through exercises that are designed for people with lung disease. You'll find more education and information about pulmonary rehab. So you can certainly check that out to do some exercises at home, especially if you're on a waiting list to get into pulmonary rehab. I will kind of point out that even in their toolkit, they say that in-person center-based pulmonary rehab is still the most effective and safest model. So I think this can be used as a great supplement or either after you've gone to pulmonary rehab or before, but definitely check that resource out. All right, we're going to pivot a little bit now. We're going to talk about supplemental oxygen. I know in our clinic, this is always the hot topic. So I thought I'd start with some of the comments and questions, statements that are made when we start talking about starting supplemental oxygen in the office. So patients often say to me, oxygen means I can't be as active as I used to be. Oxygen is addictive. Oxygen means I don't have long to live now. I can't travel with oxygen. Oxygen is going to cause a fire. I don't want it in my house. It's going to cause a fire. Everybody's going to know I'm sick if I use oxygen. The tanks are really heavy and difficult to manage. We're going to touch on each of these as we go through the rest of this talk. So let's start with, why do I need supplemental oxygen? So our lungs are made up of a bunch of air sacs called alveoli, and blood vessels run alongside of them so that when we breathe in air, the air gets from those air sacs into our bloodstream. In interstitial lung diseases and pulmonary fibrosis, the wall of that alveolus is a lot thicker and it makes it more difficult for oxygen to get across the wall and into our bloodstream. So when that happens, our saturations can drop and we use supplemental oxygen to put more oxygen into our lungs to hopefully get more across and into our bloodstream. How do you know if you need oxygen? Not every person with pulmonary fibrosis needs oxygen, right? Or they may not need oxygen at this point in their disease. So how do I monitor if I need oxygen? So we use different things to look at your oxygen levels. So we recommend that our patients have a pulse oximeter and periodically check their oxygen levels, not just when they're sitting down, but with activity, because you're going to need oxygen with activity prior to when and if you need it with rest. So getting a pulse oximeter so you can periodically check it. I caution my patients, don't make yourself crazy with the numbers. You don't have to check your pulse ox all the time, but periodically check in and keep it a sense of what's normal for you. When I walk up the stairs in my house, my oxygen level is around 94. And then maybe 6 months later, you notice, you know what, when I walk up the steps, my oxygen level is only 90 now. That would be something you could talk about with your provider. Many clinics do a 6-minute walk test where they have you walk for 6 minutes and monitor your oxygen levels. This is another opportunity for us to check your oxygen levels to see, are they dropping? And if are they dropping low enough to the point that we think you need supplemental oxygen? What is that point? If you're less than 88%, that's when we start talking about using supplemental oxygen. Another test that some offices do is called an oxygen qualifying test. This is a similar test where you you walk in the clinic and they measure your oxygen levels and figure out if you need oxygen and how much. So these are all things that you may have done periodically to keep an eye on your oxygen levels. Okay, now you've told me I need oxygen. How do I get it? So again, you're going to need a prescription from your provider. The prescription gets sent to an oxygen company, and then the oxygen company is going to deliver the supplies to you. What are the supplies, right? That's the next question. So what equipment am I going to get? So when the oxygen company delivers your supplies, they're going to deliver a couple of things. They're going to deliver what we call a home option, which is oxygen equipment to utilize in your home. And then they're going to deliver a portability option. So something when you're more active, when you're leaving your house that you can use. So we'll talk about each of these a little bit. So your home option is going to be what we call a stationary concentrator. I'm going to show you some pictures in the next couple slides of what they look like. Sometimes patients have humidification. I'll show you some pictures of that to help add some moisture to the oxygen. Some patients, instead of having a standard stationary concentrator, will get a home fill system. So this is a stationary concentrator that you can fill tanks with as well. And then the portability option. So for some patients, this is going to be portable tanks. They come in varying sizes. You can use a cart or a carrying case to move them around. And for other patients, they may have a portable oxygen concentrator. So this is essentially a smaller version of that stationary concentrator. It runs on a battery. You can plug it into the wall. The catch with the portable oxygen concentrator is they only go so high, and they can only provide so much oxygen. So for some patients, when their lung disease gets worse, the portable oxygen concentrator doesn't provide enough anymore, and we have to transition to tanks. You'll also receive oxygen tubing, sometimes face masks, sometimes what we call an oximeter. I'll show you a picture of that and explain that a little more in a minute. And that's all going to be based on what your provider orders. So here are some pictures of the things that we just talked about. So stationary concentrators, they're these big box-looking things. They plug into the wall in your house, and they're going to pull air from your the room that you're in, and it's going to concentrate the oxygen, and then it's going to send it out through tubing that then goes to your nose for you to breathe in. Over on this other side here, we have the home fill system. So it looks like the stationary concentrator, but then has an additional component where you can fill tanks. Oxygen tanks, there's a picture of them in different sizes. They're going to last different amounts of time depending on how big the tank is, what the amount of oxygen you need is. When the tank is empty, the tank is empty. You either need to have a system at home that you can fill it, or your oxygen company is going to come periodically to trade them out for you. And these are portable oxygen concentrators in the other picture in the bottom. These are going to run on a battery that's rechargeable. Typically, insurance covers the cost of one battery. And they go to varying amounts. Usually the smaller ones only go somewhere from 2 to maybe 4 to 6 liters of oxygen. And when we get above 3, they usually only do what we call pulse dose. So when you take a breath, that's when the oxygen is going to be delivered instead of it continuously coming through the tubing. And then there's bigger portable oxygen concentrators. This picture in the middle, I didn't really have something for scale, but this actually looks more like a rolling suitcase. So it's much bigger than these small portable oxygen concentrators. This particular one, I believe, if I remember correctly, goes up to 9 pulse. So as you need more oxygen, there are bigger systems. Unfortunately, insurance usually only covers these little tiny portable oxygen concentrators. So something bigger like this one is going to be an out-of-pocket expense. And then some of the other equipment that you're going to potentially receive, the oxygen tubing. Some patients utilize oxygen masks for various reasons. This bottle down the bottom is humidification. Oxygen can be very drying, so we add moisture to it to help with the drying factor. Up here in the corner, these are oximeters. So what these do is for patients that are on higher levels of oxygen, we sometimes use an oximeter, and the reservoir, so on this one, this round pendant, or the other one is under the nose, oxygen collects there, and then when you take a breath, you get a little extra in addition to what's running through the tubing. Sometimes it can let us get away with a little less oxygen. So if you need 8 liters, sometimes we can get by with 6 or 7 when we use an oximizer pendant. All right, so some of those myths. Can I travel with oxygen? Yes, you can, with some caveats. So can I fly on a plane with oxygen? You can. You can only use a portable oxygen concentrator, though. You can't take tanks on an airplane. You need to have enough battery life for your flight. Most airlines are going to require that you have 1.5 times the length of your trips. So if your trip is 10 hours, they're going to want you to have 15 hours worth of battery. You need to notify the airline. Many of them have paperwork that your provider is going to have to complete for you. But you can travel by air up to 4 liters of oxygen. The FAA does say that you can't use more than 4 liters of oxygen on the airplane. Traveling by train is a great option for some patients. I have patients that rather than flying to Florida from Philadelphia, take the train down. So we remind people to book a seat with an outlet so they can plug their portable concentrator in instead of using their battery the whole time. You should also notify the train company that you're traveling with oxygen. And if you're traveling with tanks on the train, they do have weight limits for the tanks that you take on the train. Traveling by car is also an option. There are adapters for charging portable oxygen concentrators in the car. You should notify your oxygen company that you're traveling because they'll be able to let you know when you get to your destination. Are they able to service you if you have an issue? Some companies are small and are locally based. So if you're traveling from Philadelphia to Florida and you have an issue with your oxygen when you get there, they may not be able to help you. So we should troubleshoot that before you go. And you should let your team know that you're traveling so they can help navigate all of this with you. A couple of the other things that I hear in clinic that we should touch on. So we talked about patients tell me oxygen means I can't be as active as I used to be. So I would tell my patients in clinic, actually using the oxygen is so we can keep you active. So if you're having low saturations and your body's not getting enough oxygen, that's going to decrease what you can do. But if we can bring your oxygen levels up, it's going to let you do more. And sometimes we need to make some adaptations to what you're doing, but the idea behind using the oxygen is so we can keep you active. Patients say to me, oxygen is addictive. I don't want to turn my oxygen up from 2 to 3 liters because then I'm going to have to turn it from 3 to 4 because my body's going to get used to it. It's not the way it works. Sometimes we need more oxygen because of disease progression, but it's not because you turned it from 2 to 3 and your body then got used to 3, so now we need 4. Oxygen means I don't have long to live. This is always a big conversation in the clinic. People feel like this is a big moment when we put them on oxygen. I don't want to minimize that. And certainly we have to make life changes when oxygen comes into play, right? But the idea behind using the oxygen is so that we can continue to support your body in the way that it needs to. If we're not using the oxygen and oxygen levels are dropping, then we start to develop more problems with your heart, pulmonary hypertension. So we don't want to add more problems, right, to what we already have. So we want to be able to extend your life by giving you enough oxygen. We touched on the traveling with oxygen. Oxygen will cause a fire. This is one that comes up in clinic sometimes. People are afraid that oxygen is going to cause a fire. Oxygen in and of itself is not going to cause a fire. Oxygen is going to fuel a fire faster, so you should not keep your oxygen near open flames, but the oxygen itself is not going to cause the fire. Everyone will know I'm sick if I use the oxygen. This is a fair statement, right? You now have an outward sign that something is going on. But we talk about this in clinic a lot with patients about kind of working through this. Our support group, patients that have gone on oxygen are really great at talking to other patients. And then I have patients that have come up with great ways to kind of minimize the appearance of their oxygen. So I have patients that carry their oxygen in a backpack and run their tubing kind of through their clothing to minimize kind of all the tubing. And they also, I'm not sure if they still do, but at one point they made glasses that oxygen tubing kind of was hidden in. So there are ways to kind of minimize the outward appearance, but I also think that that's something that your clinicians and your support groups can kind of help you work through. And tanks are heavy and difficult to manage. I think this is also a fair statement, but requires some creativity. I have patients that use like rollators, and they have connected kind of things to hold the tanks.
I have other patients that have figured out how to use a roller carrier really well. Different bags can help carry the tanks. And then depending on your oxygen levels, you can certainly potentially use a portable oxygen concentrator. So that's a conversation to have with your team. Some additional resources, because there's certainly a lot about oxygen that we didn't get to touch on. So the American Thoracic Society just put together an amazing website called UN Oxygen Therapy. It's unoxygentherapy.com. And they have great videos that'll walk you through kind of the different equipment and frequently asked questions. The Pulmonary Fibrosis Foundation has lots of information. I encourage you to check out their website. And then the Pulmonary Fibrosis Foundation also has an oxygen information hotline that you can call Monday through Friday, 9 to 5, and someone will be there to answer your questions about oxygen or direct you to the right people to help answer your questions. So with that, I thank you all for listening, and we're going to move into the question and answer portion of our talk.
Great. Well, I'd like to thank both Dr. Shah and Jamie for outstanding presentations covering pharmacologic therapy, non-pharmacologic therapy, and the options of lung transplantation. We do have a handful of questions that have come in from our audience. If you do have additional questions, please speak up and or submit your questions and through the Q&A, and we'll try and get to them all. So I think the first question I'll direct towards Dr. Shah here, and this is just if you could remind folks when the optimal timing is for referral to lung transplant and how you approach that in your patients who have interstitial lung disease.
That is a great question. Thank you. So I start the conversation about transplant very soon after the diagnosis of idiopathic pulmonary fibrosis. And the reason I do that is because the course can be unpredictable in IPF. And so I want my patients to know about the option. I always tell patients it's better to think about lung transplant when you're not really short of breath or on a lot of oxygen. Now, a lot of transplant centers offer video visits. So for people who are doing pretty well, they can be seen from the comfort of their own home, get some education about transplant, start to think about it. What I don't want to do is wait till my patients are really sick and then have them go through this whole process, which can be really challenging. So I bring it up early, and I think it's totally appropriate to be referred early for education and to know, I call it my back pocket card. If things go poorly, if the drugs aren't working the way we think, you have an exacerbation, at least we have this option.
Great. And so I'm going to send the next question to Jamie here. And of course, Dr. Shah, please contribute any thoughts on this. But it's the role of pulmonary rehab in preparation for lung transplantation. And, what do patients do if there aren't close by pulmonary rehab centers? Jamie, maybe you can review for us the other options. And then Dr. Shah, if you could tell us how lung transplant centers view these non-in-person pulmonary rehab options.
So there are some online options, mainly the Pulmonary Fibrosis Foundation's program. There are some more formal programs online. Sometimes they're a little harder to get reimbursed by insurance than an in-person pulmonary rehab program. And then I'll let Dr. Shah weigh in on the transplant component of it.
Thanks. I think Jamie pointed out nicely that sometimes access to pulmonary rehab is really challenging. So we always encourage all of our patients to go. The benefits that Jamie outlined are there, but if you cannot access a pulmonary rehab either because of distance or insurance, we totally are fine with you as long as you're staying healthy and active. So the reason that we really stress pulmonary rehab before transplant is because we want to keep your muscles in the game, right? So that when you have this major surgery, you can get up and walk. If we've lost your muscles in the run up to transplant, your recovery is very challenging. So most programs don't mandate pulmonary rehab. What we're really saying is we want you to continue to be active and stay fit.
Great, thank you. And along the lines of preparation for lung transplantation, we have a question from one of our participants of whether or not they should continue to take their antifibrotic medication while waiting for lung transplant.
In general, if people are tolerating the medication, I do continue them even while on the waiting list. As I showed in the table, sometimes these medications can reduce the risk of exacerbation. And as we wait for transplant, sometimes an exacerbation can be really devastating. And so I continue them. However, if for some reason we're not tolerating well, you're losing a lot of weight, your appetite is poor, and we don't think the benefits outweigh the risk, we will stop them. But in general, we continue and have not found issues post-transplant with continuing them while on the waiting list.
Great. I'm going to now go to Jamie in terms of oxygen. We have someone asking whether or not if they, is it true that once I select an oxygen company that I have to stay with this oxygen company for 5 years?
That's a great question. So it depends a little bit on your insurance, but most insurance follow the same guidelines for Medicare and Medicaid. So if you're a Medicare patient, you do have to stay with the oxygen company for 5 years. If you're private pay insurance, it may vary a little bit, but many of them do follow the 5-year rule. So what happens is the oxygen company gets paid upfront for 5 years, and then you're under contract with that oxygen company for 5 years, and another company is not going to pick you up in that 5-year period because they're not going to get paid yet. So in most cases, yes, you do have to stay with the same company for 5 years.
Great. And we're going to continue the insurance theme. I know, Dr. Shah, you mentioned some resources here, but can you remind our participants what options for medication payment if insurance does not cover these expensive therapies?
Yeah, that's a great question. There are a few different options, and I really encourage people to look at the Pulmonary Fibrosis Foundation website because they have options both from the drug companies, but there are also funds that exist just to help with medication payments. So our first line strategy as lung doctors is to appeal to your insurance to get it covered, and there are some strategies to try to do that. But if you're in a situation where your insurance won't cover it, or you have really high copays, there are a lot of resources out there to reduce the burden on you. And really, I try to make sure that cost is not a barrier for any of my patients. I think it's a commentary on our health system that medications can be so expensive. So we are really dedicated to working together with you to find a way to get these medications if that's what we think is best.
Great, thank you. So we're going to go back to Jamie here. Lots of questions about oxygen. We have a question from a participant asking, are there legal or legal ramifications for driving while using oxygen?
Oh, that's a good question that I actually don't know the answer to. Dr. Shah or Dr. Lee, I don't know if you have anything to add, but I certainly can look into that. I know that I have many patients that drive on oxygen, but I don't know if there are any legal ramifications to that if something were to happen.
I don't think so. I am not aware of any legal ramifications. You can certainly get, disability placards from the DMV for having oxygen, but they wouldn't take your license away or tell you couldn't drive, to my knowledge. Dr. Lee, if you know anything differently, please chime in.
No, I think that's correct. I think it's really with untreated sleep apnea that there might be issues related to that, but certainly none that I've heard of related to driving with oxygen. But that's something that the PFF team can circle back with our participants for. Okay. They're now coming in pretty quickly. So here we have another question here for Dr. Shah. Does the lower dose of nintedanib or OFEV still work to reduce progression? So 150 twice daily compared to 100 twice daily.
So I have dose reduced patients to 100 milligrams twice a day for side effects, and I do still think there is benefit. I am not aware, and Jamie or Dr. Lee chime in, of a trial that compared the lower dose versus full dose. But I think that if you can tolerate 100 twice a day, I recommend continuing because I do think there is some benefit to reducing lung function decline. I think you It brings up a good point about personalized medicine. Is 100 in a smaller person the same as 150 in a larger person? And I think that's really where we want to drive the field, is to better understand pulmonary fibrosis and sort of how the different categories separate and how we might treat each person with a little more individuality. So hopefully that's what's to come in the future. But I think for now, if you're on a reduced dose, but you're able to tolerate that, I think it's reasonable to continue.
Great. So Jamie, I'm going to give you another tough question. I'm so sorry. A question is whether or not liquid oxygen is available for patients.
It's a good question. So largely liquid oxygen is not available anymore. Most oxygen companies have stopped supplying it, unfortunately. But I can tell you that the Pulmonary Fibrosis Foundation and the American Thoracic Society are working really hard actually to lobby Congress to change that. So there is a lot of behind the scenes happening to try to improve access to oxygen and what's available. So hopefully that will change down the road. But right now I can tell you in the Philadelphia area, liquid oxygen is not available. We actually polled all of our oxygen supply companies to see if anybody supplies it anymore, and no one does.
Thank you. So I'm going to pull two questions together just to kind of streamline some of the questions a little bit here, and this is for Dr. Shah. Just in terms of kind of contraindications to transplant, one example is early onset Parkinson's. Is this, does that type of condition affect transplant candidacy? And then maybe more just kind of broad strokes, what are things patients should be doing in order to prepare for transplant to be good transplant candidates?
Okay, great questions. Early onset Parkinson's is very specific. And in that case, I think we would talk with your neurologist about what they think the progression will be. You know, is this something that might progress over 10 or 15 years, or are they worried that it would progress faster? Would it interfere with your mobility? But I would say there is not a clear contraindication for Parkinson's. There's probably, in that case, the details would be most important. When I tell people about preparing for transplant, I really focus a lot on fitness, so keeping your strength up. And I know that becomes so challenging as you get more short of breath and you need more oxygen, but utilizing as much oxygen as you need to allow yourself to keep your muscle strength up is so important, either with pulmonary rehab or through an exercise program. And then the other thing I really emphasize is nutrition. We didn't talk about this a lot today, but many of you are aware that when your breathing gets more difficult, when you need more oxygen, you end up burning a lot of calories just trying to breathe. And that means that you need to take in more calories. But oftentimes when you eat a lot, your stomach pushes up on your diaphragm and you feel more short of breath. And so I often really strategize about how can we have a high protein, high calorie diet? How can we use supplements? How can we keep your nutrition up? Because good nutrition is better for healing after transplant. It's better for transplant recovery. So those are the two main things I focus on. Of course, other things are controlling any other illnesses that you're dealing with. So for example, if you have diabetes, we want to see good blood sugar control. We want to see that your blood pressure is controlled. And so just making sure you stay on top of any other conditions you have, and then keeping up with your routine cancer screening. So it's very difficult to get a colonoscopy when you're really sick. So it's ideal if you've had all of your routine mammograms and colonoscopies and pap smears, whatever you need, so that those things are all done, so that if you do need a transplant, we've sort of made your life a little bit easier. Those are the things that I would recommend. And Jamie or Dr. Lee, feel free to jump in too.
That's exactly what I tell my patients too. So I think that's wonderful. And so I guess we have a clarification to one of our prior questions, just in terms of, again, timing for referral to transplantation. And I know there's always nuances with every case, and each case is different. But now that we have medications that are approved for the treatment of at least IPF, and this delays disease progression, how do we know when is really the right time for a transplant referral? When you're tolerating an antifibrotic, is it still the right time to be referred early for transplantation?
So this is a great point, and I also want to clarify when is the time to be referred and when is the time to go on the list. So I still, even with antifibrotics, I still refer my patients early. I think transplant can be really overwhelming. So I think getting that education early and then also kind of understanding what is the roadmap to transplant? What do I need in terms of caregivers? What do I need in terms of finances? All of those things better to think about early in your life. However, the next question is when is the time to actually go on the transplant list? So I have patients that I see once a year in my transplant clinic. They're doing great. We say hi. They go on about their lives. But then they're always, every conversation we say, is this the time when you should go on the waiting list, which is, then when we're really thinking about transplant. And the way we define that is when we see clear progression of your disease. So if your pulmonary function tests are going down, if you're using more oxygen, if you've had an exacerbation, if you're getting more symptomatic, more shortness of breath, if you've developed something called pulmonary hypertension or increased pressures on the right side of your heart because your lung disease is progressing, if you can't walk as far on your walk distance. So there's a lot of factors that go into that decision to say, now is the time to go on the waiting list. Now we really need the transplant. And so that is something that we will address in every transplant clinic, but in general, we're looking at signs of disease progression.
Great. And this question is probably our last question here, and not directly related to either of your presentations, Dr. Shaw or Jamie, but really in terms, we focus a lot of our treatment recommendations on the disease of idiopathic pulmonary fibrosis, but of course there are many other non-IPF related interstitial lung diseases, including hypersensitivity pneumonitis and autoimmune disorders. And so how does that play into treatment decisions in your practice?
Jamie, do you want? I can start and then I'll turn it over to Jamie. It is true that when people say they have an interstitial lung disease, there's so many different diseases that can be the specific type of interstitial lung disease, right? Or even pulmonary fibrosis. Well, what exactly is causing the pulmonary fibrosis? And so one of my first jobs in clinic is to say, why do I think you have fibrosis in your lungs? And then once I've sort of said, okay, are you in the autoimmune category? Is there something exposure related? Do I think there's something in your environment that's driving this? Or do I think this is idiopathic, or we don't know, idiopathic pulmonary fibrosis? So that is like a very critical step in trying to determine the treatment plan. And then once we have a treatment plan, the options are very different because we think the way that these lung diseases work is different. So for example, if you have hypersensitivity pneumonitis and a clear exposure, really removing that exposure is the number one option for treatment, as opposed to IPF where we don't have that. So I think to the point that it is very important to differentiate. At some point, maybe all the diseases start to group together and start to progress, and then we think about them as sort of just fibrosis. But early on, we really do want to differentiate. And I think the more that we can study and learn about these diseases, the more we can sort of personalize our treatment plans.
Amy, any final thoughts on that?
I think it's largely the same in our clinic, and we get together as a group and have a multidisciplinary discussion to kind of talk about what do we think this is, so we make sure that we have the right treatment plan, because the treatments can be very different. And so we talk as a group and kind of come to a consensus, which I think is really helpful.
Great. Well, I'd like to thank you both for great presentations and a great Q&A here. I'll wrap things up. I have an announcement from the PFF that you can order PFF safety kits totally free of charge in our shop PFF. There's a link on the lobby on the platform, and you can always find that in the store on the PFF website. And in closing, I'd like to invite you all to join us in 30 minutes in Theater 1 for this all-community networking event. It's really an opportunity to meet with others based on your connection with the PF community. There'll be breakout sessions depending on what your connection is with the community, and we look forward to seeing you there.